One important postpartum change that is asked in the previous years is about the position of your fundus in the postpartum period. Okay, so the uterus after delivery lies just below the umbilicus, and it will be involuting at a rate of will be around 1 to 2 centimeter per day. Okay, so that means by day 2, this was the question asked. Okay, by day 2 it will be 2 finger breadths below umbilicus. Okay, and let us also discuss about the weight of the uterus. So immediately after delivery, it will be around 1000 grams, and in 1 week it will reduce up to 500 grams, and by 2 weeks 300 grams, 4 weeks 100 grams, and finally 6 weeks this will be around 60 grams. Okay, so by 6 weeks it will be approximately becoming a proper pelvic organ and approximately the actual weight of the uterus also. Clear? Now let us discuss this one. We have the cardinal movements of labor here, right? So you have to remember it in order. That is the thing here. Okay, so it is engagement first, followed by descent, and descent will be happening through all the following steps also. Okay, so there will be flexion of the head, then there will be internal rotation, and then extension of the head followed by external rotation, and it is expulsion finally. So how you can remember this is using the mnemonic 8-firer. Okay, so it is engagement, descent, flexion, internal rotation, then extension, and finally external rotation and expulsion. Okay, yes, and finally it will be expulsion. So this is 8-firer, right? Okay, now what they are doing here, they are giving support at the perineum with one hand, and with the other hand they are controlling the fetal head, which is going for an extension. Yes, the baby's head is trying to extend, that extension is being controlled, right? So this thing is nothing but the modified Ridgen maneuver. Okay, modified Ridgen maneuver. So the extension is facilitated by applying pressure over perineum with one hand, and with the other hand they are controlling the elevation, that is extension of the fetal head. Check whether it is visible. Okay, now let us see this one, where you are able to see that they are giving perineal support with one hand, and with the other hand they are controlling the head of the fetus, which is going for extension, right? So this maneuver is your modified Ridgen maneuver. Okay, modified Ridgen maneuver, right? So when you do this, basically the suboccipitofrontal diameter will be emerging through the outlet. So that is approximately only 10 centimeters instead of the usual occipitofrontal diameter, which will be 11.5 centimeters. So 1.5 centimeters will be reduced, right? Yes. Now, after delivery of the baby, there will be delivery of the placenta, and delivery of placenta can happen by two methods. One is Sulci method, okay, and another one is Duncan method. Okay, so in the first method, if you see C, you have to know. Okay, so that means the separation is going to start from the center. Okay, as the separation is starting from the center, you are able to see a shiny part of the placenta is presenting, right? A smooth shiny part of placenta is presenting. So this is going to be the fetal part of placenta, right? Whereas in Duncan's method, what is going to happen is the whole of the placenta is going to slide through the uterine wall. Okay, if you see, the whole separation has happened wholly, right? And it is going to slide down and it is coming this direction. And while coming down here, the maternal surface of the placenta is going to present. Okay, so this is Duncan's method of placental separation. Is that clear? Right. Next one, yeah, this one. So what is this? What they are going to do? Yes, they are giving compression over the uterine fundus, right? So the uterine fundus is being pushed upwards as well as backwards, and with the other hand is not shown here, with the other hand a gentle traction of cord will be given, okay, and that will be downwards and forwards. Okay, so what is this? This is modified, yes, modified branded Andrews technique of placental delivery. Clear? Now, this is one component of your active management of third stage of labor. Okay, you should also know the various components of active management of third stage of labor. Okay, so active management of third stage of labor. First component is you have to inject uterotonics. Okay, so inject uterotonics within 1 minute of delivery of the baby. Sometimes they even say even after delivery of anterior shoulder of the baby you have to do uterotonic, right? And the most preferred uterotonic is oxytocin given as a 10 international units IM or IV infusion. Okay, so this is the recommended oxytocin. And the second one is we have to do delayed cord clamping. Delayed cord clamping means minimum 1 minute should be left after delivery of the baby, because this will permit up to 80 ml of additional blood to go into the fetus, that will prevent fetal anemia, right? And the third component is delivery of placenta, that is modified Bradet Andrews technique, what we have discussed now. And the fourth component is assessment of uterine tone. Okay, you have to assess the uterine tone. Okay, that can be done every 15 minutes up to 2 hours, right? So that's all. These are the components of active management of third stage of labor. Let's see this picture. You are able to see a large boggy mass here, right? That is present at the vulva. She would have been a female who has delivered just now because she is still on the delivery table, right? So this is going to be your uterine inversion. Uterine inversion. Okay. So a uterine inversion can be acute, subacute or chronic. Okay. So acute means within 20 to 24 hours, and 24 hours to 4 weeks it is going to be a subacute, and anything that happens beyond 4 weeks it is going to be a chronic inversion. Okay. And uterine inversion can happen either spontaneously or iatrogenically also. The spontaneous causes of uterine inversion include your short umbilical cord, or there is morbidly adherent placenta, especially at the fundus. Then if the female has any connective tissue disorder like Marfan syndrome, okay, and it can be iatrogenically induced by pulling the cord when the uterus is still atonic and that is combined with fundal pressure, okay, and the fundal pressure of that was given to separate the placenta was previously called as Crete's method. That's why Crete's method of placental separation is not done anymore. Okay, and when you don't know how to remove the placenta manually, proper technique of manual removal of placenta is not done, then also there can be uterine inversion, right? Yes. Now, clinical presentation, as we have seen, there will be a large mass that is presenting at the vulva. Umbilical cord may be attached or may not be attached, and additional signs and symptoms will be noted. Okay, so that will include the patient will complain of severe hypogastric pain even after delivery. Okay, and the patient can go into shock, and the shock initially will be out of proportion to the blood loss. Then there can be associated PPH also, that time it will become more severe. Okay, the patient will be presenting with bradycardia, profound hypotension like that. Okay, and finally there will be hypovolemic shock also. Okay, so all these things can happen together. Now these are the grades of uterine inversion. In the first degree, you have the uterus is partially turned. Okay, the uterine fundus is partially turned, but it is still inside the introitus, right? Now in the second degree, the fundus has passed through the cervix and it has not passed through the vagina. Okay, it has passed through the cervix, but it hasn't passed through the vagina. In the third degree, the fundus is prolapsed out of the vagina, and then finally in the fourth degree, the uterus or cervix or vagina are completely turned inside out. Okay, so this is the fourth degree of uterine inversion, right? Yes. Now let's see how to manage uterine inversion. Okay, so first thing you have to do is you have to do immediate manual replacement. Okay, with some assistance. Side by side, you have to treat her shock also. Okay, you have to offer her IV crystalloids or blood transfusion like that. Okay, and yeah, tocolytics and anesthesia can also be given. Okay, then suppose if it is not possible, after giving anesthesia, we will be trying again manual replacement. Then you will go for O'Sullivan's hydrostatic method. In that also it is not possible, means you will go for laparotomy and surgical replacement. You have two methods of surgery to replace your inverted uterus. Just know the names alone. One is your Huntington method, another one is your Holstein method. Okay, and after this we have to give tocolytic for another 8 to 12 hours, and we have to add on antibiotics also. Clear? Now, one thing you have to know while doing manual replacement of the inverted uterus is that this thing is also known as Johnson's method. Okay, so what you have to remember here is the last come part should be replaced first. Okay, so this is the principle by replacing an inverted uterus. Is that clear? Right. Now, so this is a picture where they are doing manual removal of placenta. Okay, if this is not properly done, then it is also going to cause uterine inversion, right? So you can ideally wait for placental separation for up to 20 minutes, and suppose if the placenta is not expelled spontaneously, then you can attempt on manual removal of placenta. So what you have to do is you have to enter your hand like this, okay, inside the uterus, and remember the back of the hand should be touching the uterine wall, and this one should be lying under the placental edge. Okay, and by slowly sweeping method, you should be separating the placenta from the decidua, and slowly you have to catch hold of the whole placenta and take it. Okay, so this is how you will do manual removal of placenta. Okay, so this is manual removal of placenta. Clear? Right. Now, yes, coming to the next one. Okay, so what they are doing here? They are giving a bimanual compression of the uterus. When you will attempt to give a bimanual compression of the uterus? Yes, in PPH, right? It is postpartum hemorrhage. So this is bimanual compression of uterus, and here they have put a Buckley balloon catheter to stop PPH. Okay, so here is a Buckley balloon catheter, right? And yeah, so these are some of the sutures that are given for postpartum hemorrhage when it is not controlled by other methods. Okay. So, in the first image, you are able to see a cesarean incision, and through that a suture has been passed and it is going through the incision here. I hope you are able to see the black color here, and it is coming out again. So, this is going to be a B-Lynch suture, right? And in the next one, you are not able to see any incision here, but you are able to see two separate sutures that are compressing the uterus vertically, and you also have horizontal cervico-isthmic sutures. So, what is this? This is going to be a Hayman suture. Okay. And finally, multiple square sutures are given. So, these are your Cho square sutures for PPH. Clear? Right. Now, if PPH is not controlled by suturing also, then we will go for stepwise devascularization. And remember, stepwise devascularization is done in this order only. First, you will go for uterine artery ligation, that will be done unilaterally, then converted to bilateral uterine artery ligation. Then, uterine artery is having an anastomosis with the ovarian artery. So, you will be going for ovarian artery ligation, unilateral and bilateral. And finally, you will go for the internal iliac artery ligation bilaterally. Okay. So, this order is important of stepwise devascularization. Clear? Now, let's discuss about the management of PPH in general. Okay. So, first we have general medical management, that is hemostasis is the key word. Okay. So, here we have hemo. So, H for ask for help, then A for assess. Assess means assess the vital parameters like BP, pulse, etc. Okay. Then E, you have to establish the etiology of PPH. We have 4 causes, right? That is 4 P's. What are the 4 P's? That is tone, tissue, thrombin and trauma. Okay. At the same time, you have to ensure the availability of drugs as well as blood components. Okay. So, drugs and blood components. Drugs will include your erythropoietin, syntrophin, oxytocin. Okay, like that. And then M, simultaneously you have to massage the uterus, and finally O is again you have to start your oxytocin infusion. Okay, as well as if it is possible you can start giving your prostaglandins as well, right? Then it is stasis. Okay. So, stasis is for the stepwise surgical management, right? So, S means first shift her to operation theatre and start bimanual compression. Okay. And you can even put anti-shock garment while shifting her to the operation theatre. Then T means you have to exclude tissue and trauma and proceed on to tamponade. Okay, so balloon tamponade we have seen, right? So, tamponade can be done, or even you can go for a uterine packing, right? And finally, A. Okay, A means apply. Apply what? Compression sutures. We have seen so many compression sutures. So, you can apply any of the compression sutures. Then S means systemic devascularization. Okay, systemic devascularization. What is the order I told you? It is going to be uterine artery followed by your ovarian artery followed by your internal iliac artery, right? And then it is going to be your I, which is interventional radiology. I is going to be your interventional radiology. You will go for uterine artery embolization. And finally, yes, that is you will go for hysterectomy, subtotal or a total hysterectomy. Okay, so this is how you will manage PPH, right? Yes. And now, one more additional point, PPH is the direct cause of maternal death. Okay, PPH is going to be the direct cause of maternal death. Okay, whereas most common indirect cause of maternal death is, indirect cause means, yes, it is going to be your anemia. Anemia is the most common indirect cause of maternal death. Clear? Now, see this baby. You are able to see that the baby is just like this turtle. Okay, you are only able to see the head of the baby. The rest of the body is lying inside the shell, which is nothing but the maternal abdomen here. Okay, so what do you call as? This is nothing but your turtle sign, right? So turtle sign is seen in which condition? It is seen in shoulder dystocia, right? It is seen in shoulder dystocia. Okay. So when you have shoulder dystocia, immediately you have to perform this maneuver. What maneuver is this? This is your McRoberts maneuver. Okay. So in this picture, what you are able to see is the knees are pulled towards the chest, right? And suprapubic pressure is also applied. Okay. So two components are done simultaneously. So this is your McRoberts maneuver, right? So what is done? First one, the legs are abducted and then sharply flexed upon the abdomen. Okay. So what is being done in this procedure means it straightens the sacrum relative to the lumbar vertebrae and it rotates the pubic symphysis towards the maternal head, so that what is happening, there is decreased in angle of pelvic inclination. And also one more thing that is happening is we are freeing the impacted anterior shoulder also. Okay, impacted anterior shoulder is also free. Okay, so these are the things that are happening with this maneuver, so that will be helping in delivering the impacted fetus. Okay, and it depends upon the mobility of the sacroiliac joint, right? Yes. Now coming to this maneuver, what they are trying to do, they are just trying to leave their hand inside the vagina and they are just trying to rotate the fetus, right? Okay, so this maneuver is nothing but your Wood's corkscrew maneuver. Okay, so posterior shoulder, okay, ideally they will be trying to rotate from this side. Okay, so the posterior shoulder is rotated in a corkscrew manner, right? Posterior shoulder is rotated in a corkscrew manner and it will be rotated approximately around 180 degrees to bring it anteriorly. Okay, and when it comes under anteriorly under the symphysis pubis, this shoulder will be delivered. Okay, usually this method is done under general anesthesia. So this is your Wood's corkscrew maneuver, right? Now let's discuss how to manage shoulder dystocia. Okay, first you have to call for help. Then you have to give a generous episiotomy and you have to have an assistant by side to give suprapubic pressure. Then you will try McRoberts maneuver, and if it fails, we will be going for Wood's corkscrew maneuver, and then you will be extracting the posterior arm, and if this is also not possible, you will go for fedotomy, and finally it is going to be a Zanavalli procedure. Okay. So one important point I have to tell with the McRoberts maneuver is that, remember, this is going to be your suprapubic pressure. Okay, suprapubic pressure. Sometimes they can confuse you by giving fundal pressure. Okay, it's not fundal pressure, it is going to be a suprapubic pressure. Okay, yeah. So, what is this maneuver? See, they are trying to, the arrow showing like this, okay, inside. So, they are trying to push the fetus inside. So, this maneuver is nothing but your Zanavelli maneuver. Okay, so the head is pushed into the vagina with anesthesia and the baby will be delivered by cesarean section. Clear? Now, let us see this image where you are able to see a distended lower uterine segment. Then you will have a depression here. Okay, so this is nothing but your Bandel's ring. Okay, so usually when the woman is in labor, normal shape of the abdomen will be maintained. Okay, but when there is Bandel's ring in case of obstructed labor, what happens? There will be a distended lower uterine segment and a retracted upper uterine segment, and the center you will be able to see Bandel's ring. Clear? So this is how it will be. So this is Bandel's contraction ring, which will be seen through the abdomen itself. Okay, it will be seen over the abdomen itself. Whereas a constriction ring can also form, but it will not be visible that much over the abdomen. Okay. Now let's try to make out the difference between constriction ring and retraction ring. Retraction ring is something which is seen in your obstructed labor, right? So first is constriction ring and next is retraction ring. Retraction ring is nothing but your Bandel's ring. Okay. So a constriction ring is a manifestation of localized, incoordinated uterine contraction. Okay. Whereas a retraction ring is the end result of tonic uterine contraction and retraction. Okay. And basically a constriction ring is due to irritability of the uterus, whereas retraction ring occurs following your obstructed labor. See, both these rings are usually formed at the junction of upper segment and lower segment, but in constriction ring the position does not alter. Okay, whereas in a Bandel's ring or a retraction ring, the ring progressively moves upwards, right? So these are the important difference between constriction ring and retraction ring. Now, they have given 3 clinical pictures. Like in the first picture, you are able to see the baby is having hydrocephalus. In the second pic, you are able to see there are intracranial calcifications, right? Intracranial calcifications, and finally you have this fundal picture where you are able to see chorioretinitis, right? It is chorioretinitis. So all these 3 are together seen in which condition? Yes, it is toxoplasmosis, right? So it is seen in toxoplasmosis. So some important points of toxoplasmosis. This is caused by the intracellular parasite Toxoplasma gonadie. Okay. Mostly it is an acquired infection by ingestion of the infected material. Sometimes congenital infection can happen to the baby if the woman is pregnant by transplacental route. Okay. See, the infection rates are more in 3rd trimester, followed by your 2nd trimester, followed by your 1st trimester. But the complications will be more if the mother is getting infected in the 1st trimester, right? And the clinical features, just now we have seen. What are the clinical features? The triad of symptoms: hydrocephalus, intracranial calcifications and chorioretinitis, right? But remember, 70 to 90% can also be asymptomatic at birth. Okay. So, how will you diagnose in this condition? You will diagnose this condition by checking for maternal IgG, which indicates past infection. Okay. Neonatal infection means you will be getting IgM, neonatal IgM, right? How will you treat this condition? So, treatment can be offered. If the infection is present in the mother alone, you will be giving her spiramycin. Okay, this will reduce transmission rate by 50%. Suppose if infection is present in the fetus also, that is also confirmed, means you will be giving spiramycin along with pyrimethamine. Clear? Right. Now, coming to the next picture. Yeah, you are able to see microcephaly, patent ductus arteriosus and cataracts. So, this triad is seen in which infection? Yes, it is your rubella, right? So, rubella infection. Know that rubella is a single-stranded RNA virus. So, this is usually a mild self-limiting illness and transmission is maximum seen during first trimester, where you will be seeing many complications also. Okay, so what is the rubella triad? Rubella triad consists of these three features. Okay, it is microcephaly, patent ductus arteriosus and the cataract, right? So, let us see what are the features that are associated. Okay, already we have seen there can be microcephaly, patent ductus arteriosus or cataract. We can also have glaucoma, growth retardation, blueberry muffin lesions and hepatosplenomegaly also. Now, coming to the next one. So, in this image, you are able to see a microcephaly. This is a normal head size and here you see you are having microcephaly, and what you see here is periventricular calcifications along with ventriculomegaly. Okay, so these features are seen in your cytomegalovirus infection. So, cytomegalovirus infection. Remember, cytomegalovirus infection is one of the most common congenital viral infection. Okay. Here the rate of transmission is more common in the third trimester, followed by your second trimester and followed by your first trimester, whereas severe infections are seen in an inverse order, right? And transmission can occur by any route. Okay, so it can occur by saliva or urine or genital secretions, blood, breast milk, etc. Okay. So, let us see the features of cytomegalovirus. In CNS, as we have already seen, there will be microcephaly or periventricular calcifications. You will have ventriculomegaly. You may even have ophthalmic findings like chorio, retinitis and sensory neural hearing loss. Okay, and remember, cytomegalovirus is one of the most common cause of sensory neural hearing loss. Okay, and in the skin you may have petechiae, purpurae, and gastrointestinal features can include hepatomegaly, and hematologic features are also seen, that will include your anemia, thrombocytopenia and splenomegaly like that. Okay. So, for diagnosis in the mother, if you see IgG positivity, then it suggests past infection. Suppose IgM is positive, then it suggests recent infection. Okay. And how you will diagnose it in the neonate? The virus has to be isolated from the urine or saliva in the first 3 weeks of life. Okay, that indicates it is a congenital infection. Okay. Then coming to the next one. Now you are able to see vesicular lesions here, right? So vesicular lesions are seen in herpes simplex, right? So it is going to be a herpes simplex infection, and it can be caused by HSV1 or HSV2. Okay. So here the infection will occur through the genital tract to the fetus, and primary infection has a greater transmission rate when compared to reactivation of the virus. Okay. So most of the times the baby will be asymptomatic at birth, and between birth and 4 weeks the disease can occur in 3 patterns. Okay. So either there can be SEM, that is skin, eyes and mouth disease, or there can be any form of CNS disease, or it can be a disseminated disease as well. Okay. So how will you diagnose this condition? By using Zank test, right? So what is Zank test or Zank smear? How do you prepare? By scraping the base of the vesicles. Okay. And for the infant, cultures can be taken from the skin lesions or oropharynx, eyes, urine, CSF or even blood. Okay. So how do you treat this condition? Treatment can be given by giving acyclovir 400 mg TDS for 7 days, right? And important thing to notice, you have to do delivery in these patients by cesarean section, because there is a high chance of infection through the maternal genital tract. Okay. So normal labor is not allowed, only you will go for cesarean section, right? Yes. Coming to this one, yes, you are able to see so much of cicatricial lesions here. Okay. So this is seen in your congenital varicella syndrome. Okay. So this is a congenital varicella syndrome. Okay. So the incubation period for this infection is usually 1 to 3 weeks. The disease is more infectious before 48 hours, that is just before the rash appears, and after the vesicles crust over. So it may take even 5 days, right? So what happens after the primary infection? The virus is going to remain dormant in the sensory nerve root. Sensory nerve root ganglia, and when reactivated, it will cause the herpes zoster lesion, right? So what are the features that are seen in the infection? So in the mother, there will be flu-like illness or anything like vesicles will be seen definitely. There can be pneumonia, then encephalitis or even hepatitis can be seen. Okay. And for the baby, you will be seeing skin lesions with scarring. Okay. That is cicatricial lesions. Okay. So there will be even limb contractures, cataract, microcephaly and cortical atrophy as well. Okay. So, and for treatment, for the pregnant female, you will give acyclovir, and for the child, that is the neonate, you will give varicella zoster immunoglobulin. Is that clear? Right. Now in this picture, you are able to see that a mosquito is infecting the mother, that is transmitting the virus to her bloodstream, and from the bloodstream, the virus is entering into the placenta and transplacental transfer is happening and it is infecting the baby, right? So the potential adverse outcomes that are seen in this disease is microcephaly, intrauterine growth restriction, ocular abnormalities, fetal death. Okay. Other long-term effects are unknown. So what do you think this disease is going to be? It is going to be a Zika virus. Okay. So the same kind of question was given in one exam where the same scenario like transmission and the baby showing microcephaly pictures was given. Okay, so this is Zika virus infection, right? So the management is only symptomatic management here, right? Yes. Coming to the next one. Yes. So what do you think this is? This is going to be a snuffles. Okay, so that is nothing but your persistent rhinitis. So this is seen in which condition? Yes, congenital syphilis. Okay. When we talk about syphilis, it can present in two phases. Okay, so it can be early congenital syphilis that will be presenting between 0 to 2 years, where you will have snuffles or hepatosplenomegaly. There can be syphilitic pemphigus also. Okay, pemphigus, that is nothing but you will have vesiculobullous lesions over the palms and soles. Okay, and another feature is in the X-ray, you will be having bilateral erosion of the upper tibia, which is known as Wimberger sign. Okay, and in late congenital syphilis, which will happen after 2 years, the features will include Hutchinson's triad. Okay, so what are the components of Hutchinson's triad? You have Hutchinson's teeth, then interstitial keratitis, and also sensorineural hearing loss, even saddle nose, peritonitis, everything, periostitis can also occur. Okay. One important question that they ask you is Kesowitz law in syphilis. Okay, so it is your Kesowitz law. So what does this law states? That even if the female is untreated for syphilis, the character of pregnancies that she can end up will improve gradually in the next pregnancies. Okay, so for example, in the first pregnancy, she had a miscarriage. Then, in the second pregnancy, she had a second trimester loss. Then in third pregnancy, she had a stillbirth. And in fourth pregnancy, she will go for a live birth. Okay, so this is how the improvement in pregnancies will be seen in syphilis. Okay, so this is your Kesowitz law, right? Now, what is this? This is a Foley's catheter, right? So, Foley's catheter. What are the uses in obstetrics? So, in retention of urine for continuous bladder drainage, then we can use this for amnio infusion, also in providing uterine tamponade while treating PPH. Okay, so these are some of the uses, right? Okay. Now this instrument, when you see, this is a straight forceps, right? So first point, this is a straight forceps with a ratchet lock. Okay, you have a finger ring handle and the tips are toothed. Okay, you have 4 to 5 teeth on each side. So this is going to be a Alice tissue forceps. Okay, so Alice tissue forceps is basically used in many procedures. For example, in DNE to grasp the anterior lip of cervix, and in cerclage procedures to hold the lips of cervix. Then it is also used in cesarean section and hysterectomy also in various steps. For example, in a cesarean section, we can hold the skin, margins of the skin, as well as peritoneal margins, as well as to hold the angles and margins of uterus as well. Okay. Yes. Coming to this instrument. So, what is this instrument? This instrument has got a concave blade, right? So, this is going to be a shaft part and this is going to be a groove part. Okay, you see a groove here basically. Okay, so this is a bivalved one and this is a single walled speculum. Okay, so what is the speculum called as? Yes, it is going to be a Sims speculum. So, this is your Sims speculum. So, this instrument is used in various procedures in obstetrics. Okay, it can be used in dilatation and evacuation or circulatory procedures, and this will be useful to visualize amniotic fluid leakage also when you suspect a case of PROM. Okay, right. So, this speculum has goes anterior and posterior blades, right, and this also got a fixation screw as well as a handle. Okay, so this is your cuscous bivalved speculum. Okay, so this is going to be a cuscous bivalved speculum. Okay, so the advantage of this speculum is this is a self-retaining as well as adjustable speculum. Okay, but the disadvantage is anterior vaginal wall cannot be seen properly with the speculum, and it can be used in various procedures while taking a pap smear and to confirm PROM, to detect cervical incompetency, and to diagnose any lesion that is present over the cervix, right? Yes. Now, this is also one speculum where you have a blade. Okay, you have a groove here. Okay, so this is a groove, and here you have a heavy ball. So, the name of the speculum is overt speculum. Okay, so this is also a self-retaining speculum because you have a big ball here. This weight itself will be suspending itself as a self-retaining speculum. But the disadvantage is that you need anesthesia to use this speculum because there will be so much pain if the weight is pulling down, right? When you see this instrument, you should see that there are openings in both ends as well as over both ends you are having serrations also like this. Okay, so these serrations will be fitting into the vaginal wall. Yes, it is a anterior vaginal wall retractor. Okay, so that you will be able to retract the vaginal wall, right? So this can be used to visualize the cervix in both obstetrics and gynecological procedures, and in PPH it can be used with the blunt fluoride to remove the products of conception as well as membranes also. Okay, right. Now, so if we see this instrument, this is a long instrument which can be applied to the anterior lip and posterior lip of the cervix. This is nothing but your valsellum. Okay, usually this will be around 20 centimeter in length. Okay, so you have an interlocking sharp teeth here that will provide a firm grip, okay, while you are holding the cervix. Then you have blades, okay. Yes, so valsellum is basically used to hold the anterior lip of cervix for cervical procedures. So that can be your IUD, So that can be your IUCD insertion or a cervical insertion. So valsellum can be used to hold either your anterior lip of the cervix or posterior lip of the cervix depending upon the procedures. Okay, it will be used in both obstetric and gynecological procedures like DNC or IUCD insertion, or in hysterectomies like a vaginal hysterectomy, or even Fothergill's operation like that. Okay, in so many procedures valsellum is used. Okay, you have a disadvantage in using valsellum, that is there will be cervical bleeding and trauma. Okay, so it is good that we don't use it in DNC, that is when you are doing DNC for a miscarriage, you will not be using glycerin, you will be using a sponge holder which will be comparatively soft. Clear? Right.